Hello, and welcome to the Asthma and Allergy Foundation of America's latest education program, Understanding Mild to Moderate Asthma. Today's program is developed independently by AAFA and made possible with generous support from AstraZeneca. We are so glad you're here. My name is Stacy, and I am the Public Health Manager here at AAFA. You will also meet my colleague and our speaker here in just a moment. But before we start, I would love to tell you a little bit more about who we are. The Asthma and Allergy Foundation of America aims to be a trusted ally of the asthma and allergy communities. We are dedicated to saving lives and reducing the burden of these diseases through support, advocacy, research, and education. Without you, our community, we would not be here. So thank you. Thank you for everything that you do for those everywhere living with asthma and allergies. Again, my name is Stacy, and I am happy to be your host for this program. Your speaker, whom you will meet in just a moment, is Dr. John James. And finally, we have someone very special on the back end, ensuring that everything throughout this program is running smoothly. And her name is Zulima, and she is our support center manager. Now, let's review a few house rules. Everyone's video and audio are on mute, but we would love to hear from you during the program through our chat box. So at any time, if you have a question about anything we are discussing, please type your questions into the question box. We will be unable to answer specific questions about your case, but we do encourage you to bring those questions to your doctor at your next doctor's visit. So throughout today's programming, we will also have some polling questions, and we would love and encourage you to respond to these polling questions. And in addition, please take a moment at the end of the program to complete the survey questions. Your feedback will help others by providing valuable insight into your experience and helping us plan for future educational programming. So with that, let's talk a little bit about our agenda today. We are going to begin with a brief overview of asthma, what it is and what the triggers are. We will then identify some asthma symptoms, very common asthma symptoms, and then talk about some that may not be so common. And then we're going to discuss what it means when asthma is controlled and what it takes to manage your asthma. We are also going to discuss available treatment options, even new treatment options that target underlying inflammation. And finally, Dr. James will guide us through a discussion and questions on what you might want to bring to your next visit with your doctor so you can work together on developing your own treatment plan. Here are our disclosures. And our speaker today is Dr. John M. James, MD. Dr. James is a board-certified allergist, and he is also president of Food Allergy Consulting and Education Services, LLC. He has worked as a medical specialist in the field of allergy, asthma, and immunology for over 30 years. Dr. James received his bachelor's degree from the University of Arkansas and his doctor of medicine degree from the University of Tennessee. He is board certified by the American Board of Allergy and Immunology, and Dr. James is no stranger to AAFA, and he has led numerous webinars with us, as he also staffs the Ask the Allergist program. He has also participated in other educational initiatives with us and in many of his own. So please, everyone, welcome Dr. James. Hi, Dr. James. How are you doing there? Good to see you. Okay. So here at AAFA, we love getting to know our audience and our community. And if you feel comfortable, please share your thoughts on how you keep your asthma under control. So I would love, audience, if you would like to participate in this poll. Let's open our poll, Zulima, and consider to keep my asthma under control, I mostly use A, my quick relief inhaler like albuterol, B, my steroid inhaler or controller medicine like Qvar, Pulmicort, or generic Flovent. C, my inhaler that has multiple medicines in one device like Symbicort, Dulera, Airsupra, or Advair. D, I go to the emergency room when I have asthma attacks or episodes. Or E, I do not currently use medicine to control my asthma, or maybe I just don't know. And there's no single single answer to this question. You can have more than one answer, and there's no right or wrong answer. So while our audience is thinking about this, this question, I would love to talk a little bit about the support center. And one of my favorite parts about calling into the support center is if you have a question, such as I have a question about my inhaler, or I have a question about a trigger of mine, you can call in the support center and ask about that and get an answer and direct you to online resources or places you can call and request the type of assistance that you are looking for. So, Zulima, let's see about closing those polls, and let's see what our most common answer is. All right. Wonderful, wonderful, great. Thank you all so much, audience. And now we have one more question. Audience, if you feel comfortable, I have one more question for you. So let's open our polls as we answer this question. One way asthma can be managed is by A, daily contact with triggers, B, taking your quick relief every day, C, treating underlying inflammation with a controller medication and a quick relief medication as needed, or D, using a humidifier. So let's take a moment to answer. And as we close the polls, I would like to thank our audience for participating. And let's see what our most common answer is. It looks like it is C. So we'll find the answer to that later on in the program, more towards the end. So thank you, audience, so much. I am now going to hand over the program to Dr. James. Dr. James, please tell us a little bit more about mild to moderate asthma.
Thank you so much, Stacy, for your introduction. I also want to thank Zulima for being here for support. And finally, I want to thank the Asthma and Allergy Foundation of America for their help in devising this webinar and all their support. Thank you, everyone who's attending today. I know there's a variety of attendees, parents, healthcare providers, and others interested in asthma. So thank you so much for being here. So what is asthma? Asthma is a chronic lung disease that causes inflammation and narrowing of the airways, making it hard to breathe. This can lead to common asthma symptoms, including cough, wheezing, shortness of breath, and chest tightness or pain. Asthma affects both children and adults, and it is the most common chronic disease among children. There is no cure for asthma, but it can be controlled with the right combination of medications and trigger control strategies. When medications are taken properly as prescribed and triggers are controlled, most people with asthma can lead a healthy, active, and normal life. Next slide. With asthma, there are three main changes in the airways. First, asthma causes swelling inside the airways from inflammation and overproduction of mucus. Second, this excess mucus and inflammation can clog the airways, making it difficult to breathe. Third, tightening and squeezing of the small muscles around the airways causes the airways to become narrowed. This is known as bronchospasm or bronchoconstriction. All of these things cause the airways to become hyperreactive or hyperresponsive. That's one of the hallmarks of asthma. Asthma symptoms commonly include a combination of cough, wheezing, shortness of breath, or chest tightness or pain. All of these symptoms don't have to be present, but many times at least one or two of them are present, if not all. And in this illustration, you can see a normal airway on the left. It's wide open, there's no inflammation, air is getting in and out very easily. In the middle panel, there's swelling of the airway and increased mucus production, causing some obstruction or difficulty getting the air into the lungs. And then in the final panel, this is just an example of what would happen in an asthmatic airway during an attack. There's increased swelling and inflammation of the airway. There's increased mucus production, and those smooth muscles we talked about can tighten around the airway, causing constriction. So it is more difficult to get air into the lungs, into those air sacs called alveoli, where oxygen is exchanged with carbon dioxide. So this is a really good illustration for asthma airways. Next slide. During an asthma episode, the small muscles around the airway squeeze and tighten. And as I said earlier, this is called bronchospasm. Quick relief medicines target these muscles to relax and are typically short acting. A good example would be albuterol. I'm sure almost everyone on this webinar is familiar with this medication. These are called bronchodilators or short acting beta agonists. And I'm sure that many of you are very familiar with these. Next slide. Let's go a little bit more in depth and discuss the role of inflammation in asthma. Did you know that the short-acting medicine or quick relief medicines cannot get rid of or control the underlying inflammation that contributes to asthma and asthma episodes? Quick relief medicines should only be taken when needed and only work to reduce the airway tightening or bronchospasm we showed earlier. You need a medicine that targets and reduces inflammation to control asthma effectively. This group of medicines are called asthma controllers. When someone with asthma comes into contact with an asthma trigger, such as an allergen in the air or an irritant like pollution or cigarette smoke or changes in the weather, the airways can begin to swell, produce more mucus, and become inflamed. This is your immune system responding to those triggers, which can activate inflammation in the airways and lungs. This is why if we target and control inflammation, we can lessen asthma symptoms and improve overall asthma control. Next slide. There are many medications that can treat asthma. They are divided into two main categories on this slide. First, there are controller medications like budesonide, which your provider may have you take daily, even if you aren't having symptoms. Controller medications address the underlying issue of asthma. For example, they reduce inflammation and overproduction of mucus, which can narrow the airways and make it difficult to breathe. They work slowly over a long period of time. Secondly, there are quick relief medicines, albuterol I mentioned earlier, that are used as needed. They don't treat underlying inflammation or overproduction of mucus. They do, however, relax those smooth muscles around the airways, which helps to open up the airways and create more space to move air into the lungs. These medicines work quickly and they do not last long. So usually the quick reliefs are about 1 to 4 hours in length of action. In addition, there are combination asthma medications that aim to control and relieve asthma symptoms. We're going to discuss these in more detail later in the presentation, and I'll give some examples of those as well. If asthma symptoms are not controlled and you're just not having good overall results with medicines, or your control is not good, your doctor may refer you to an asthma specialist, and other add-on therapies may be needed. Next slide. So this is just a terminology review because there's a lot of people on this webinar, so I want to make sure we're paying attention to that and giving everyone a good chance to have a good foundation and baseline. So we'll be using these words throughout the program. Some may be new to you and some not. First of all, there are short-acting beta agonist and long-acting beta agonist. So we'll go through bronchoconstriction first. That's what I've been talking about up to this point. It's the tightening and narrowing of the airways. An asthma exacerbation is an episode with increased asthma symptoms such as cough, wheeze, chest tightness, and shortness of breath. Bronchodilators are medicines that relax those smooth muscles of the airway, decrease obstruction, and make it easier to breathe. There are quick relief medicines, such as short-acting beta agonists, and there are also long-acting bronchodilators. Inflammation refers to redness and irritation in the lining of the lungs with increased mucus production. Anti-inflammatories and controller medications treat and decrease inflammation in the lungs. So these are essentially in the same category. Inhaled corticosteroids are examples of anti-inflammatory medications. Lastly, there are combination asthma medications that include both bronchodilators and anti-inflammatories. Next slide. Up to 70% of all people with asthma people with asthma have mild asthma. And this form of asthma is more common in childhood. Mild to moderate asthma doesn't mean it's a little bit of asthma. It's a severity classification of asthma. Individuals with mild to moderate asthma are still at risk of severe episodes of symptoms and episodes. In fact, those with mild asthma, 30 to 40% of severe episodes require emergency care. Finally, fatalities from asthma can occur. In 2020, there were about 4,000 deaths from asthma recorded. This is why it's so important to have a correct diagnosis, regular follow-up with your healthcare provider, and an effective asthma treatment plan. Next slide. There are different severity levels of asthma. Mild to moderate asthma is defined by the frequency of symptoms and risk of exacerbations. For example, how often are you having daytime symptoms, nighttime symptoms, such as cough, difficulty breathing? The severity also depends on how often you use your quick relief inhaler. Is it daily, weekly, monthly to manage your symptoms? In addition, asthma severity looks at how often your asthma symptoms interfere with everyday activities. Can you exercise how you like to? Can you get up and go to work or school effectively? Assessment of lung function and impairment helps to classify asthma severity. And these are things like spirometry in your doctor's office. Finally, the Global Initiative for Asthma, otherwise known as GINA, define mild to moderate asthma as non-severe asthma, which can be controlled by steps 1 and 2 up to 3 treatment. We're going to talk about this later in the program. These guidelines are parameters that help your doctor to diagnose what type of asthma you may have and the severity of it. We will discuss the GINA guidelines again later. Next slide. I like this slide because it helps to illustrate the 4 main severity levels of asthma, from intermittent to mild to moderate to severe. Let's explore each level. So in intermittent asthma, you have symptoms less than twice a week and wake up less than 2 times per month. With mild persistent asthma, you have symptoms 2 or more days a week and wake up 3 to 4 times a month. Moving to moderate persistent asthma, you have symptoms at least every day, so this is very significant, and wake up 1 or more nights a week. And finally, severe persistent asthma, symptoms during the day and wake up every night due to asthma. This is almost continuous problem with asthma symptoms. So next slide. So granted, this is a very busy slide, but I put it in because I wanted to import some other features that determine asthma severity. The previous slide highlighted the importance of asthma symptoms. There are 2 other components that help define severity. The first of these is the use of quick relief medications. And this would, in this slide, you can see in the intermittent, they're not using their short-acting inhaler very often. When you get into the mild, you can be using it greater than 2 times per week, but not daily. And in the moderate persistent asthma, we're seeing the use of the short-acting reliever on a daily basis. The other factor is the interference with normal activities. In a mild intermittent patient, they really have no limitation to activities or exercise, physical education, things like that. In the mild persistent, there can be minor limitations in activities, exercise, work, and maybe school. And finally, in the moderate persistent, there's definitely some limitation in normal daily activities. And the final piece of the severity classification involves lung function. So in mild intermittent, and this would mainly be spirometry. FEV1, which is the forced expiratory volume in the first second, is measured in spirometry. It's a very good measure of airway obstruction. So in the mild intermittent, there should be no decrease in that. And in the mild persistent patients, you might not see any decrease in the FEV1 or other spirometry measurements. As you get into moderate persistent, that's when we start to see decreases in lung functions, like the FEV1 could go down to 60 to 80% in patients who have moderate persistent asthma. So I won't cover anything else there, but we'll go on to the next slide. Just as every person is different, so is their asthma. In general, individuals with asthma have some common symptoms that we've talked about earlier: coughing, wheezing, shortness of breath or rapid breathing, chest pain, or tightness. And they may present differently for each patient. And so every patient doesn't have always the same symptoms, but these are very common symptoms we would expect to see. Other problems include other symptoms like trouble talking, exercise intolerance, or problems with sports or other activities, disruption of sleep, very common symptom in asthmatics, lethargy or decreased energy, and anxiety or other similar psychological symptoms. Next slide. So there are also early warning signs and symptoms of asthma that can be different from those classic symptoms I mentioned on the previous slide. These include increased mucus coughed up from the lungs, maybe a runny nose, stuffy nose, congestion, which could be seen in like a viral upper respiratory infection that can trigger asthma, an itchy neck or chin, which can be maybe a symptom of allergies, which certainly can be a trigger for asthma, feeling tired, weak, or lack of energy. I'd mentioned lethargy on the previous slide. Shoulders being raised or slouching because there's an increased work of breathing because of airway obstruction and inflammation. Hoarseness to the voice or difficulty talking or speaking. Dark circles under the eyes, which can be seen in patients with allergies like hay fever or allergic rhinitis, and those things can be associated with asthma. Nighttime symptoms, changes in behavior, because maybe there's poor sleep at night, which can change behavior during the day, and definitely struggle with exercise. This is a very common feature seen in asthmatics, having difficulty with vigorous exercise and exertion. So your healthcare provider, physicians can use diaries to track symptoms and signs of asthma. And this can be very useful in the asthma action plan and devising a plan on when to use medications and how to adjust them. Next slide. So when you notice early symptoms and warning signs, don't wait to act. There are specific things you can do to keep your asthma under control. And I have some features here I wanted to cover. First of all, I want to talk about the asthma action plan. I think many of you are familiar with this. This is something you can consult and follow. It's like a communication plan or a roadmap for what to do when your asthma is well controlled, when it's partially controlled, and when it's not well controlled. It should be a written plan that is developed with your healthcare provider. This can be used, the patient can keep it, you can give it to other caregivers, to babysitters, to teachers at school, to people at work. Should be an easy to follow plan that communicates the medications, the how to adjust medications, when to seek care for exacerbations or episodes of asthma. So communicate with your doctor or healthcare provider. You can call, text, email your provider, whatever system is in place with your provider. Go into the office if needed for an acute care visit. Hopefully this can prevent emergency care visits and hospitalizations, but sometimes those are needed. It's important to tell your doctor how you're feeling, and if your asthma is getting worse, or at times it's just an emergency and you need to get instructions about what to do. So follow your asthma action plan and use it as your guide. And lastly, on the right, there's the asthma control test. I think many of you are familiar with this. This is a questionnaire that helps your provider determine how well your asthma is controlled. It consists of 5 questions with 5 answers each, and it gives a score for asthma control. A typical good score is 20 points or higher. If a score is 19 or less, it can depict not well controlled asthma. And I'll give a couple of examples of questions on the survey. One would be, in the past month, how often did you have shortness of breath? And the next question that I'll give an example is, in the past month, how often did you use your quick reliever, such as albuterol, for asthma symptoms. So this 5-question survey can be very useful in generating a number or a score, an assessment that your provider can use, and we can get an idea how well you were controlled over the past month or so. And this will be helpful in adjusting the asthma action plan, just talking about medications and other control measures for your asthma going forward. Next slide. So asthma control is essential to asthma management, and there are several steps you can take to ensure your asthma is well controlled and managed. Ensure that you keep up with your clinic appointments with your doctor or specialist to monitor your asthma. This can include reviewing the history, the healthcare provider doing a physical exam to listen to your heart and lungs, and doing some lung function assessment like a peak flow rate test or spirometry to do those objective measurements of your asthma control. Some clinics have asthma educators, nurse educators, respiratory therapists that can be very helpful in asthma management and deliver education to help in your overall asthma control. Part of the asthma management plan is to learn about your triggers, identifying them, and knowing how to remove them so you don't set off your asthma. For example, if there are environmental irritants like scented candles or scented cleaning products that can trigger asthma, you will need to replace them with unscented products that would not aggravate or trigger asthma. This way you can still enjoy your home life without being triggered by things that might be used for cleaning and things in your home. So other triggers like pollen in the air, animal dander, molds, those are the triggers we would be talking about for control. And then we'll talk about medications, and we're going to go into this in more detail, but these are built into your asthma action plan. They can be reviewed at the follow-up visit, and adjustments can be made if needed. So if all this is put together, there's a good lifestyle balance. Your asthma is under control. You're able to do all the things you want to do. Participate in sports, go to work, go to school, and completely be active and not have to miss activities or miss school or work, miss sporting events because your asthma is not controlled. Next slide. So this slide really lays out the main asthma triggers. And we'll start on the left there. So allergens would be things like pollen in the air, tree pollen, grass pollen, weed pollen, animal dander, cats and dogs, for example, molds and dust. These are common allergy triggers. Irritants like passive cigarette smoke, air pollution. Respiratory illnesses, viral upper respiratory illnesses like the flu, RSV, respiratory syncytial virus, COVID-19. Strong emotions we mentioned earlier, that anxiety, stress can play a role in asthma triggers. Exercise, about 80% of patients with or individuals with asthma have an exercise trigger. Weather changes, going from warm weather to very cold weather or having severe thunderstorms, these things can trigger asthma. Gastroesophageal reflux disease or GERD can trigger asthma. Not as common, but food allergies can trigger asthma, especially if there is a severe allergic reaction like anaphylaxis that can trigger the lungs and cause asthma symptoms. And some medications, such as non-steroidal anti-inflammatory drugs like ibuprofen and some cardiac meds like beta blockers, can trigger asthma. Next slide. So the goals of asthma management are outlined here. The overall goal is to achieve the best possible long-term asthma outcome. Long-term asthma symptom control is to make sure that we have few asthma symptoms and symptoms are relieved quickly. Not waking up at night with asthma symptoms. Allowing you to participate in your daily activities with no complications. And decreasing your asthma risk with asthma management is to achieve little or no exacerbations or episodes, improving overall lung function that we discussed earlier, and no requirement for oral steroids or oral corticosteroids, which can have side effects. We want to avoid those at all costs. Next slide. And this slide summarizes the risk of uncontrolled asthma. So what's happening if your asthma is not controlled? You're not seeking appropriate care. You're not following an asthma action plan. Uncontrolled asthma symptoms can put you at risk for severe asthma exacerbations. Having any of these risk factors listed below can increase your risk of asthma exacerbations or episodes, even if you have just a few asthma symptoms. So first, if you're overusing your quick relief inhalers like albuterol and you're not using your controller inhalers, then if you're not using them correctly, well, you're not going to be under control, and this can put you at risk for complications from asthma. Other medical conditions like obesity, chronic sinusitis, GERD, which is reflux, pregnancy, confirmed food allergy, these can be comorbidities that contribute to risk of uncontrolled asthma. Exposure, I mentioned previously, like passive tobacco smoke, allergen exposure, and air pollution. Stressors like anxiety can play a role and can put you at risk for uncontrolled asthma. Lung function measurements like the FEV1 or forced expiratory volume in the first second on spirometry, well, if it's low, like we talked about in the moderate persistent asthma, that's going to put you at risk for uncontrolled asthma. Next slide. So one of the keys to this presentation is we do not want our individuals with asthma or our patients to treat only with quick relief medications. So don't treat with only quick relief medications. These medications like albuterol treat symptoms, not the underlying disease. They are not addressing the inflammation of the airways in asthma. People with mild asthma can have severe or even fatal exacerbations. And I mentioned earlier that 30 to 40% of these people can have severe episodes. Regular use of quick relief medications like albuterol can lead to overuse of this medication and relying on this medication, which can be associated with an increase in asthma episodes or flares. So they are not a primary asthma treatment. Next slide. So this is sort of a new concept, that asthma therapy, to many of you. It's been around for a little while, but we really want to focus on this today. So this slide summarized the concept of anti-inflammatory reliever therapy, otherwise known as AIR. It addresses the limitations of traditional asthma management, which often uses separate inhalers for maintenance and relief. This approach to therapy can improve adherence to asthma therapy and reduce the risk of asthma exacerbations or episodes. It involves the use of a single inhaler containing both an inhaled corticosteroid, like budesonide, and either a short-acting or long-acting quick relief medication. The short-acting would be like albuterol, and a long-acting would be budesonide. And these can be used on an as-needed basis to manage symptoms and reduce exacerbations, different from approaches we had used many years prior to these new guidelines, such as the GINA guidelines and guidelines from the National Institutes of Health in the United States. So an example of this would be a short-acting bronchodilator plus budesonide. An example of this would be AirSupra, which has been approved in the United States by the Food and Drug Administration for asthmatics 18 years of age and older, including those patients with mild persistent asthma. And the example of a long-acting bronchodilator and budesonide would be Symbicort. Many of you may be familiar with this medication. These are combination inhalers, and they fall into this group known as anti-inflammatory reliever therapy. Next slide. So we wanted to pull one recent publication from the Journal of American Medical Association in 2024. So this is very recent. And this is looking at inhaled reliever therapies for asthma, both the short-acting and the anti-inflammatory relievers I just mentioned. So this study, these investigators looked at how well quick relief medicines like albuterol alone worked when people took them for their asthma, as compared to groups of patients who used inhaled corticosteroid medicine, budesonide, combined with either a quick relief albuterol type medication or a long-acting bronchodilator, formoterol, work with patients when they took them to relieve their and control their asthma symptoms. So this study was made up of 27 randomized clinical trials, a large group of studies brought into one with over 50,000 adult and pediatric patients. Next slide. So this study showed that the use of an inhaled corticosteroid combined with either a quick relief medicine, albuterol, or a long-acting bronchodilator, formoterol, was able to reduce asthma exacerbations and improve control when compared to the use of the quick relief albuterol alone. So again, the examples here would be for the albuterol plus the inhaled corticosteroid would be Airsupra, just to give you an example. And the example for the long-acting bronchodilator would be a medication called Symbicort. Because this can seem confusing, I would just make sure we all can be on the same page here. So, and both of these inhaled corticosteroid containing relievers did not significantly increase the risk of serious adverse events compared to the short-acting bronchodilators alone. That's very important. Next slide. So I wanted to pull this from the Global Initiative of Asthma program. And this, I think this paradigm or this overall goals gives us an idea of why it's so important to have asthma control and management plans. So it's assessing the patient, adjusting treatments, and reviewing the therapy to make sure we're doing the right thing. It's not a static thing or written in stone. It can change over time, needs to be reviewed and looked at. So in the assessment phase, we're confirming the diagnosis. We're assessing the symptoms, how they're being controlled, what are risk factors, the comorbidities like obesity and sinusitis and GERD. How are patients using their medications? What's the technique? Are they adhering to the plan? And what is the patient's preferences and goals? What are we addressing? What the patient and their caregivers want from us in terms of what they want to achieve in this treatment plan. Going to the adjustment plan, we're treating the modifiable risk factors and comorbidities. So if it's obesity, we're addressing that. If there's sinusitis, we need to address that. If it's GERD, we look at that. What non-pharmacologic strategies, so it's exercise, having a healthy diet, other factors like that. Definitely looking at asthma medications, including the use of inhaled corticosteroids, which are really can be the foundation of the long-term asthma management. And then education and skills training. There's that action plan again. So important to have that written plan with your healthcare provider. And then moving to the review stage. Reviewing symptoms. Are they controlled? Oh, if we can go back, Stacy, to the previous slide. Thanks. I just want to finish here. So reviewing symptoms. Have they had exacerbations in episodes? Are they having side effects from medication? We need to address that. If we can, doing lung functions, measuring spirometry or peak flow rates, seeing if the comorbidities are controlled. All of these things in this wheel need to come together to have good asthma control and management. And again, it's not written in stone. We have to make adjustments. We have to listen to the patient and caregivers to provide the best plan. Now we'll go to the next slide. Now, this is one illustration from the GINA, most recent GINA report. The GINA report is a group of asthma specialists. This includes allergists, asthma specialists, pulmonologists, other healthcare givers to gather evidence-based data in asthma management and putting it into a report. The great thing about this report is it's reviewed and updated every year. Many of you may be familiar with this. Another corollary to this would be the National Institutes of Health Expert Panel report for asthma management. But it gives us guides and for healthcare providers and even patients to follow what is currently being recommended for asthma care. So at the top, there's that wheel again, assessment, adjust, and review. So I'm just today going to focus on adults and adolescents 12 years and above. So there are a couple of tracks that are shown here, and we'll mainly focus on step 1 and 2. And in this, as we mentioned earlier, in that anti-inflammatory reliever, this is one of the medications I mentioned, as needed only, low dose inhaled corticosteroid like budesonide and formoterol. The example here could be Symbicort. Using this in step 1 and 2 can be a very effective way to decrease asthma symptoms, decrease asthma episodes and exacerbations. And below there it says reliever as needed, low dose the inhaled corticosteroid formoterol. So it can be as in that reliever category for sure. So it's going to provide the baseline of therapy for asthmatics. And then in step 3, just an example, this is when we're really getting into the maintenance therapies for asthma. So using the combination therapy, or sometimes it's just the inhaled corticosteroid alone, but that is devised with your healthcare provider in the asthma action plan. So track 2 would be the alternative to track 1. And this is, again, the anti-inflammatory reliever therapy, how this can be important. And if you see the reliever there, it says as needed ICS, which is inhaled corticosteroid, and SABA, which is a short-acting beta-2 agonist or bronchodilator. That is what is depicted there. And that would be the example I mentioned earlier, AirSupra, which is the only FDA-approved therapy in this category in the United States. And it, again, is approved for ages 18 and above. So in step 1 and 2, this reliever, anti-inflammatory reliever, can be used for symptom control, symptom relief and control, and to prevent asthma episodes, exacerbations, and other complications that can occur from asthma, like going into the clinic for unscheduled visits, or even the emergency room, or being in the hospital. So I wanted to just give one example from the GINA report. This also has recommendations for children under 5, which they are going to be using inhaled corticosteroids as their controller medication, usually in step 3. And there's also a group ages 6 to 11, but for time's sake here, I'm not going to focus on that today. So I wanted to overview these therapies that you should be aware of. Again, the anti-inflammatory reliever therapy is a more new concept in asthma management, and hopefully this is something that you can review with your providers and put it into your asthma action plan as needed and as appropriate. Next slide. So we really want to have this goal of developing a treatment plan for successful management of our asthma. And these are questions that you can ask your healthcare provider. But even going before that, I wanted to discuss shared decision making a little bit. Many of you are familiar with this. Shared decision making is when the patient and the caregiver come together with the healthcare provider and have a discussion about what the goals are, what the patient's goals are, what is going to be on the table for discussion about symptom control, and how we're going to achieve those things. So it's not a one-way communication. It's a back and forth communication with patient, caregiver, provider, and maybe asthma educators and other folks involved to have that discussion. So it's not paternalistic, like going from doctor just telling the patient what to do. It's a combined teamwork strategy. So here's some questions you could bring up during shared decision making. What is the severity of my asthma? So we talked about that. So classifying that can be helpful in the plan. What are the potential side effects of my asthma medications? So we definitely want to address that. And I mentioned oral corticosteroids can have side effects. We want to eliminate the use of those if possible and only use them when they're absolutely necessary. Should I use a spacer device with the inhaler? Not all inhalers need spacers, but some do, and they can help deliver the medication to the lungs. And how are they used? What should I do if my asthma symptoms increase or if I have an acute asthma attack? That's where the asthma action plan comes into play, and it needs to be updated at the follow-up visit. So reviewing it, making sure that it's working, or do adjustments need to be made going forward. And this can be a written plan that can be distributed to other people that are involved, like caregivers, school health techs, teachers, and people at work. How often should I have follow-up visits to monitor my asthma symptoms or control? Well, typically, if the asthma is under good control and it's mild, it may be a visit every 6 months, definitely once a year. But sometimes visits have to be more frequently, every 3 months, and then acute care visits if needed. That's where when the asthma action plan directs you to call your provider, and then a decision can be made about coming into the clinic, reviewing what's going on, making adjustments, preventing emergency room visits and hospitalizations. Can I participate in sports and exercise? Absolutely. This is so critical. We want our patients to be fully active in physical education, in sporting events, in doing individual care exercise plans. We do not want people to be sedentary and not participate because they think they can't. We want people to be fully active, and that's one of our goals. Are there new treatments for my asthma? Well, one of the concepts we talked about today were the anti-inflammatory reliever therapies, and there are many therapies under investigation will be coming available in the future. That's where talking to your healthcare provider, hearing about those GINA guidelines, like global initiatives for asthma, paying attention to what you hear. If you hear things in the media, talk with your healthcare provider and doctors about what does this really mean? Is it something we should address? So all of these questions are a way that you can take these to your provider. I think we're going to provide a handout in a link that you can use these when you're seeing your healthcare provider for you or your children who have asthma or other people that you know that have asthma. So we'll go to the next slide. I think it's the final polling question. So this is the knowledge check. We had this earlier, and we'll just review it one more time. One way asthma can be managed is by a daily contact with triggers. B, taking your quick relief every day. C, using a controller medication, quick relief medication as needed. So that's a combination therapy, or using a humidifier. So we'll let that sit for a bit, Stacy, and then you can take over from there.
Thank you so much, Dr. James. And I see we have a few more answers coming in, rolling in. So we'll take just a few more seconds before we close the poll. But I just want to thank you so much for your time and your expertise in sharing with us more about mild to moderate asthma and the underlying inflammation and new and exciting treatments that we can look into and talk further with our own healthcare providers back at home more about to help control and manage our asthma. So I know I have learned a lot about mild to moderate today. So thank you so much. And with that, I think our poll can close and let's find out our answer. And it looks like answer C is our answer and also the most common that was selected as well. So thank you so much, Dr. James. And before anyone goes anywhere, I would love to share a little bit more about resources that you guys can take with you back home. So not only the materials that you can find on this webinar, they're in the top right-hand corner under the materials tab. Please take those home, that asthma action plan, that developing a treatment plan with your healthcare provider. Those are so crucial and important in your healthcare journey. But I also want to talk a little bit about our AAFA store. You can go to our AAFA store to find out more educational resources and learn about programming there. You can also hang out and call Zulima at the support center, 1-800-7-ASTHMA. If you have a question about anything related to asthma or allergies, or even questions about how to join our online communities, you can call that number at the support center and ask her how to do that, and we will direct you to local and online resources to answer your questions. So those are really great resources to have in your back pocket. You also can learn 24/7 in our learning catalog that we have, and at any point if you have a question you want to ask Dr. James, something about allergies or asthma, you can join Ask the Allergist and submit your questions, and they will also be answered. So thank you so much for letting me share those resources. And I noticed some really great questions everyone has sent in while they registered. So at this point in the game, I would love to have Zulima come on board and Dr. James come back and turn it over to both of you to answer some of these questions and answers that we have received. So with that, Zulima, I will hand it to you.
Thank you, Stacy. We received some great questions from the audience. So, Dr. James, we will kick it off with the first one. Does mild asthma improve with age?
This is an excellent question, one we receive quite often. Mild asthma can improve with age, with recognition of the processes we talked about today, the underlying reasons to have asthma, to address symptom control, control of triggers, following up with your healthcare provider. All of these things can help to improve mild asthma. And we might see patients with mild to moderate asthma go to mild asthma to even mild intermittent asthma. So this is very encouraging. I try to stress this with patients when I see them and their caregivers that it can improve. But on the other hand, it can worsen with age if asthma is not controlled, because the airways can become inflamed, can become have involvement that's hard to reverse with age. So again, treatment is so important. Recognition, treatment, follow up, reviewing, making adjustments, are all the underlying asthma itself. Probably never the tendency to have asthma. We don't think that ever goes away, but it definitely can go. The severities can improve with age.
Thank you, Dr. James. Our next question, can mild asthma change into severe asthma or vice versa? And you kind of touched on this in your previous answer.
Yes, and this again, if an individual has mild asthma and they're not paying attention to their asthma symptoms, getting good management of their asthma, overusing quick relief medications, and just relying on those and not addressing the underlying inflammation and things that can change with the airways over time, yes, mild asthma can move into moderate asthma and can move, unfortunately, into severe asthma over time. And that's because you're just not addressing the underlying causes of asthma and having a good asthma action plan and having follow up with a provider. But also, if moderate asthma is addressed and controlled and have a good action plan put into place over time, that moderate to severe asthma can improve with age, and you can have much better outcomes. So don't think that it's just going to go mild all the way to severe and never get better. No, there's ways to treat, ways to manage asthma that can make huge differences in your overall quality of life, ability to participate in sports and activities, and have that balanced life we talked about.
Absolutely. Our next question is, if I take a rescue inhaler, do I also need a daily inhaler?
So this is a great question. So the question I would like to know is how often they might be using it. But if you're using a rescue inhaler, it's what we talked about early in the program was that anti-inflammatory reliever therapy. We're learning that this approach to therapy is going to be the better approach because you have that quick relief with that medication, but you're also addressing inflammation. So if you're just using that rescue inhaler, you're really not addressing the underlying causes and mechanisms of asthma. um, if we see patients that just rely on that albuterol inhaler, they're using it as their only treatment and they're frequently using it, thinking this is my medication for asthma, but they're not really addressing the overall important features of asthma. So that was one of the main points today of the presentation. We need to be thinking about the anti-inflammatory reliever therapies as really the better current approaches to asthma therapy.
All right, our next question. This is a popular one I see as well. What is the difference between a pulmonologist and an allergist, and when should I see one for my asthma?
Okay, this is a great question too. I think the first thing I would say is if you can find out if the pulmonologist or the allergist, it's best to find one of these physicians who is board certified, because these are certifications that we receive from our specialties that have gone through the training and the follow up, the continuing medical education and the maintenance of certification to be in our specialty and be experts. So an allergist or asthma specialist can do all the things we talked about today, as well as a pulmonologist. Both of these specialties can evaluate for asthma, can manage asthma, and do follow-ups for asthma. And it may depend on the age of the patient. So the allergy and asthma doctors see patients of all ages, from really infancy up to adult years. Pulmonologists might be more geared for older adolescents and adults. So that could be a feature. And if you have features that you want to address with allergies, environmental control, the allergist is going to be better there. The pulmonologist might be dealing not only with asthma, but other lung diseases. So there are multiple things that could go into this. I think it's important to get a board certified specialist here, and you might even talk to your friends and other people that have and find out who the best person in your area to see would be. You can also check with specialty societies to get names for recommendations for assessment and care.
All right, and our last question. Can a poor air quality index day cause my asthma symptoms to flare?
Absolutely. I think this area there's been more and more um, emphasis on this area over the past decade or so for good reason. Uh, Poor air quality can contribute to irritation of the airways, inflammation of the airways, increased mucus, and in asthmatics and patients with other lung diseases, this can be a problem. So we're talking about particulate air matter, the air pollution, um, ozone, strong chemical irritants that can be in the air, not only in outdoor air, but in indoor air. So we want to pay attention to quality of our indoor environments and our outdoor environments. And there are multiple things that are being looked at here, not only by our specialties, by the Environmental Protection Agency. Asthma and Allergy Foundation of America does a wonderful job with air quality control and putting this in their website and out to their constituents. So this is an area that is so important. And you can get information from local news media, from social media, but you can find out this information fairly easily and use that information to build that into your action plan to have the best control of your asthma symptoms.
Thank you so much, Dr. James. That concludes our question and answer portion of today's program. Stacy, I'll hand it back to you.
Thank you so much, Lima. And again, thank you, Dr. James. And we would also love to thank our audience for participating with us throughout the presentation today. And I'd especially like to thank AstraZeneca for their generous support of this educational programming. All content was developed independently by AAFA, the Asthma and Allergy Foundation of America, and we are so thankful for you joining us today. Thank you all and have a great day.